Good morning and welcome to the next episode of our podcast,
where we drink tea and navigate the balance between school and personal life.
I'm Sophia Safe.
And I'm Sophia Curry.
And this is Sip and Spill. Welcome to Tea Time Talks.
Basically, we're starting a new supplemental series, as we've already done multiple times.
Many times.
But this one is where we interview medical professionals about their job, and then we, tie in a mental health connection to, maybe them personally and how their job affected them, but also how mental health affected their patients.
Absolutely. And these will be starting as medical connections to mental health. Today we have a very special guest joining us. So he is a cardiovascular cardiologist at Reading Hospital. So now we're just going to jump right into some introductions. So welcome to the interview. Why don't you start by introducing yourself?
Thank you for inviting me. It's a great opportunity. My name is Hassam Saif. I'm a cardiologist. I'm also a specialist in vascular medicine. And I treat patients both in the field of cardiology and the medical side of the vascular biology and vascular medicine.
Okay, so our first question for you, we're going to start in with education and science background. So our first question is, what science classes in high school or college helped you the most?
So, it might be kind of a little bit of a wrong person kind of question, because I didn't go to school here, but I went to school in Pakistan, and over there the classes were essentially kind of the same. We were taking biology, in which it was divided into botany and zoology, and also organic chemistry, physics. It wasn't as heavy as on calculus the way it is over here. The math part was taken out, but it was very heavy in physics and chemistry.
So you deal with a lot of medical students in your work, right? So do you see a lot of them using their biology, chemistry, or physics showing up in their education?
Oh, absolutely. Like, for example, even when I was going through med school, it's the same medical education almost all over the world. It's just they divided in per month or per year a little bit different. So at that time, you don't really realize that when am I going to use physics? But fast forward 10 years after that, when I was taking my echocardiography boards, the ultrasound of the heart and the ultrasound of the blood vessels, physics was a huge chapter in it, and you had to know it to pass the exam. And then I realized, oh my God, it really helped. In pharmacology, chemistry, the reaction, the biochemistry, the reaction of the chemistry, it's more of an organic chemistry because you're talking about a human here. So yes, it does help, no doubt.
That's great. I think it's really important for a lot of kids to hear that. I know a lot of kids, when they walk into school, they're like, this has nothing to do with what I want to do. Why am I doing this? Especially when you go into Englishes and all that, but even specifically sciences.
I would say specifically physics. A lot of kids struggle with that a lot and struggle to see the point of it. Like, oh, I'm going into medicine. Why am I ever going to need physics? But knowing that you're going to be using it in the future, it can really motivate someone to take it.
Yes. Tremendously.
So did school prepare you for the emotional side of medicine?
So I would say high school and college, not really, but med school really helped me, because in med school you have, like in US, you have 2 years of just classes and 2 years of then your rotations in the hospitals, and you work like a resident. You don't have so many responsibilities, but you do work hard, and it's tiring. It prepares you, but it does feel like a storm when you are an intern on your day one as a resident. You have an inclination because you work with interns as a medical student, but when it's your skin is on the line, it surely feels a little different.
I think that's one of the main parts of medicine that a lot of kids might not think about. Because I know I heard a lot of my parents like talking about how kids might meet doctors who like don't care about the emotional side, or very like monotone. Do you feel that like that emotional part is important when you're dealing with clients?
So there always be emotional side of things. I have been in the field of medicine since 2001. That's when I started to go to medical school. And to this point, there are days that it kind of hurt you. I mean, not to completely de-identifying the information of a patient that I saw them very recently, that I just sat there in the room with them and didn't say a word. And the patient asked me, "What?" And I'm like, "I don't know what to do for you. I just don't know." And she was like, "I know. Every doctor has been saying that." And it's a gut punch. No matter how callous you get, you will get a gut punch at some step. One day, once a month, once a year. But the callous nature helps. For example, when you're doing a CPR. When as a resident, as a fellow, I did CPR. I mean, it was just amazing that not even for a second in my head I thought that I am doing it on a human, because a good CPR will break ribs. I heard cracking under my palms. I heard gurgling from their mouths. My focus was perform a good CPR. I'm gonna make sure they survive. But not for a second came to my mind that, oh, it's a human, I'm hurting them. No, the goal was very straightforward. For example, when you are operating on them, if you are too emotional about it, you might not be able to do a good job. And that's why a lot of doctors are told not to treat your family member. So much so that Cleveland Clinic, that where I did my vascular medicine fellowship, they had a rule in the hospital that you cannot prescribe a family member any medicine. You have to go through someone else because emotions are involved.
That's, I think, similar to my parents, and even the psychological field, where they're not allowed to treat anybody they know because that emotional involvement piece, and it can really hinder your care for the person.
Absolutely.
So then our next question is, what surprised you most when you first entered the medical field? And this can be your first experience with it in med school in Pakistan, or if it was more surprising when you came to the US, then what surprised you there?
So med school is a little different in a sense that you are just swimming and splashing hard just to survive. You just want to learn, pass, move on, next year. You tend to open your eyes a little bit more after your med school and training, because in training it's like, this is what I gotta do. You just wake up at like 3 in the morning, show up at work 4:30, and come home at 8, pass out, get up, rinse and repeat. What I was surprised, and I do get surprised almost every week even now, the more I learn, the more I realize how much we do not know about human body, how complex it is. Same age, same gender, same condition, different reaction to the same dose of medicine. It is just mind-boggling that how so many things run us, so many things tick us. The food, the air, the psyche, because they're not in the same house. Is that playing a role? How much do you sleep at night? How much do you eat? When do you eat? And what do you eat? Just like, the more I know, the more I'm like, yes, that is, human body is tough. Human body is tough.
You feel like it gives you a rewarding feeling every time you learn something new that like altered this medical condition, or like made that slight change?
Absolutely. What So in my field, on the cardiology side of things, the most rewarding thing for me is identifying a patient who is kind of a ticking time bomb. So many times they would come in, they would say, "Oh, I'm having chest pain or shortness of breath." Be like, "Okay, what's this? What's that?" And I'm like, "Okay, you know what? Let's go for this test. Doesn't look good. Let's go for it." And they end up requiring a bypass surgery. So these patients are the one they just has sudden death. So my field, by the grace of God, I can identify these guys. Okay, we gotta act now before it's too late. And on the other hand, it's very disheartening as well. And that has happened so far only once, that I told patients something and they didn't listen, and they were found dead in bed afterwards. So that part is also very tough, that you just want to convince them that, hey, this is the right thing to do, I know what I'm talking about, and they're like, nah, I don't want it. But most of the time they do listen because they are having issues.
So you deal a lot with death in your profession and passing.
Yes.
So does that affect your mental health at all? And if so, how do you deal with it?
So it's always the first question when one of my patients, usually they pass away most of the time when they're in ICU really sick. So you kind of expect that they're not doing so good. And rarely you hear from the family member that, hey, they passed away at home. Our office is good in that sense that family member contacts us. They contact the cardiologist that, hey, your patient passed away. The first question always comes to mind, did I do enough? Did I do enough? And that kind of eats at you at times. And rarely it's like you're like, no, they're in a better place. Dealing with the family member is very tough in that situation. You got to understand their psyche as well, what they are going through. And you have to read the room. You have to read the room very intently. So when I entered the room, there are like usually 6-7 family members in the room. The patient is on the respirator. So the first question I ask, I'm like, may I know who's in the room? And then you know who will have most of your eye contact. And then I start with, I'm sorry. Yes, they are 90-year-old. They are, they knew they were going to pass away in the next 6 months. Their condition is like untreatable. But you just say, I'm sorry. Just be human about it. I see a lot of doctors these days, not a lot, but there are doctors out there who just like be a very monotonous, robotic kind of a tone. Do I go and hug the family member? Of course. I mean, reading the room. Reading the room is the key. The patients that I know from a long time, they are admitted, I go see them. I go for a hug. I don't even say a word. I just go and hug them. I don't hug everyone. So the psyche is important to understand who to talk to someone. Some family member wants to know the facts. What happened? Blah, 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 blah. Usually these are engineers. They want to know, for them, everything is black and white. And then I tell them, in engineering, in physics, in chemistry, there is black and white. In field of medicine, it's gray. Nothing is black and white. It's all a giant pond of gray paint in there. This thing works for this guy. This thing won't work for that guy. And it's just trial and error with the strong knowledge base and experience.
I think that's really important for a lot of people, because I think a lot of people think medicine is very black and white, and it's not. I think that's really hard when a patient passes. I mean, I've seen it with my family members when someone passes. They want to know all the facts and they want to know what happened. Hey, some things just didn't work out. And I think that's very telling. And I kind of like that medicine's a gray area. I think that's something that draws me to it, is that there's more to it than you think. But if you could redesign the science education for future doctors, what would you change?
The mental health aspect, absolutely. In our medical school, back in Pakistan, and here I'm in charge of our cardiology rotation of the medical students. I don't see a dedicated mental health unless they ask for it. The focus is getting there a lot in medical schools, in residencies even. It used to be a norm to do 80-hour weeks. Now they make sure that you never have to do more than 24-hour call at a time. It used to be easy 36 hours straight, all because of mental health. I wouldn't say all because of mental health, predominantly because of mental health and because of the tiredness not to have errors. Because in this field, if you're not in the right place physically or mentally, people die. I mean, it sounds very dramatic, people die, but yes, they do. So that's what I would change, that focusing more on the mental toughness of the field. I see our new generation is a little bit weak on the mental toughness side of it. They have gone to the other side a little bit more, that they're like, oh, I'm freaking out. If you are freaking out easily, this is the wrong field. You have to be compassionate. You have to be open about your mental health, but you have to stand up for your patient. If you're freaking out, your patient, who's going to take care of them, right? So that's what I would change.
And we're going to talk a little bit more about mental health in cardiology specifically later, but to begin with, I want to talk to you more about what you do in your job. So what exactly does a vascular cardiologist do on a daily basis?
So my field is slightly different in the sense that I am boarded in cardiology and I'm boarded in vascular medicine as well. So, but predominantly I practice cardiology around 80% of the time. And this entails seeing patients in the hospital, seeing patients in the office, reading studies like ultrasound of the heart, stress tests, whether it's ultrasound mediated stress test or nuclear stress test. And then I also read vascular ultrasounds as well and see patients in the office with vascular conditions. So it's day to day. Usually the hospital rotation is usually a week long, because you want to see the same patient every day. You want to see the progress every day until they're discharged. But the hospital rotation is very tiring. You show up early morning, you work whole day, you round whole day, you teach the resident, you teach the fellow, you teach the medical students. So they don't let you do it more than a week, because it's very exhausting. And you work straight 7 days. The office and the lab is divided half and half. Sometimes you are whole day, 1 day in the lab, or someday you are half a day in the lab or half a day seeing patients in the office. By lab, I mean you're doing stress tests and echoes. Echo is ultrasound of the heart, or vascular ultrasound, or the TEE, for example, is an ultrasound of the heart with the probe that goes through the mouth in the food pipe in the esophagus, and that's how we do the ultrasound of the heart. So it's all divided.
What kind of conditions do you see most often?
So believe it or not, or rather you would, it's understandable, it's actually high blood pressure. Our food is, I mean, unfortunately, very pro high blood pressure. And our weight overall, it plays a huge role. So if you look at overall our community, we are generally overweight and our foods are not great. So high blood pressure is the one that I see a lot in my field. And then the second most I see is the coronary artery disease, means the narrowing in the coronary arteries, which stems from high blood pressure and cholesterol issue. And the third most is the cholesterol.
Then, what is the most challenging part of your job?
The challenging part of my job is convincing people that prevention is better than cure. That's I've struggled with people. Weight loss is such a magic pill, but it's hard. It's every time you lose any weight, it has direct effect on your blood pressure, on your cholesterol, on your blood sugar, on your joints, on your psyche even. You must have heard the statement, the feeling of skinny is better than any taste of food. But you gotta be there first to have the feel of the skinny. And people just don't understand that, okay, if I lose weight, your joints feel better.
And by skinny, you don't mean aesthetically skinny.
Aesthetically skinny, I mean not be having an average, I don't want to say it, but average American all over the world is considered as a big obese guy. By skinny, I mean normal weight, BMI of 18 to 25 kilogram per meter square.
You mean healthy.
Healthy weight. But the statement is out there, the feeling of skinny is better than the taste of food. Yes, but that part of my job is really hard, to convince them.
Where do you think people kind of have a constraint against that? Is it their just lifestyle, or where's the hesitation?
The hesitation is healthy food is expensive.
Mm.
Healthy food is not available where most of our obese population is, inner cities. When my wife and I used to be in Philadelphia, inner city, we used to walk for, if I remember right, at least 5-6 blocks to go to a store to get our fresh produce. And it was always more expensive than the suburbs. And if you see, the fast food is cheaper than the produce, the fresh fruit and the vegetables. And that's the most processed food out there. That'll make you gain weight, that'll have a lot of salt in it, high blood pressure, obesity, cholesterol, diabetes, all of them are stemming from that. So that's, I think, and education, of course.
Mhm.
Education is the key as well.
So then what's your solution to this problem?
Education. Education, education, education. If people are educated enough, they can still make smart decisions within the confines or constraint of their income. It's like these days, I have really simplified it. You cannot talk to a farmer of Berks County about the macros, that this much protein and this much carb and fat you have to have in food. You're going to lose him right away. So my teachers, what they taught us, I just give it forward like, hey, follow the 3 simple rule. Anything that flies or swim, you can eat. Anything that walks the earth, you can't eat. You can bake chicken, fish, nothing 4-legged you can eat. Right? Simple rule. You can bake, boil, broil, you cannot fry. Simple. Third rule. Anything that's in a box or white in nature, avoid it.
And do you recommend these for everyone or just
Everyone. Everyone. And the simple rule. When you're eating and you feel like you have 2-3 more bites left to feel full, that's the best time to stop.
Do you follow these rules yourself?
I'm a very wrong person to ask this question because I have a very meticulously strict diet.
Oh, okay.
My breakfast is weighed, my lunch is weighed, my dinner is weighed. the calorie intake, it's within 10 to 15 calories a day. I can give you an exact number. And that has really helped me. The older I'm getting, I'm realizing that if I don't eat right, I gain weight very quickly. If I monitor what I'm eating, if I'm not losing weight, I'm maintaining it.
So I'm going to stray a little bit off the path here, and I want to talk a little bit about diet culture within teens, where a lot of teens I know struggle with like eating disorders when it comes to, for example, anorexia or eating too little.
Mhm.
And so the feeling of skinny is better than the taste of food, that phrase is sometimes used like as an argument against that. And so I was wondering what's your opinion on that and whether it's different for these kinds of people.
Education.
What do you mean by that?
We are not educated enough in foods. I will take you back 10 years, 15 years. My mom was visiting. I was preparing for an exam. She was cooking. I was eating. I was studying. I gained weight. And I was struggling with it a little bit, weight wise. And I thought, I'm eating well. I'm a doctor. I know what I'm eating. My food is great. I started to write it down, what I was eating. It was an eye opener. My calories were all off. My protein, carbohydrate, and all these things were way off. And once I fixed all that, I started to lose weight. Now it has gone the other way in these teens. Skinnier the better. But the consequences are dire later on. You have problems all the way from your teeth to your, intestines. So the only thing is the education that can educate these folks that, hey, this is not the right thing to do. In my field, I see mostly old people. And all the things we do in our youth, that shows up in that age. Whether it's eating disorder, eating too much, or eating too little.
Important to maintain that balance.
Of course, absolutely. And that's why you have a BMI range of 18 to 25 kilogram per meter square. That, hey, if you're in between this 18 to 25, you're normal. And so on the same side of things, there was a study which showed this obesity paradox, that people who were slightly overweight, like BMI of 26, 27, they did well after a big surgery, cardiac surgery, compared to the super skinny people who were like on 18, 19 BMI range. Because they had a little bit of a reserve to fight. That's what the thought process was. So the idea is that don't aim for 18, don't aim for 25 either. If you are between 18 to 25, you are leading a normal, healthy life.
And so we're going to move back a little more onto the path of just generally about your job. What I know we touched into this, but what is like really for you the most rewarding part, like out of anything?
Being able to help people. Like, I've heard this statement a few times, but you can never get used to it, that thanks, Doc, you saved my life. That's a huge statement. I didn't do anything. I just identified it. I'm not an interventionalist. I did not put in a stent. I did not do the bypass. I only identified the patient. Hey, you need something. Let's go get it done. And they come back, they go for a procedure or bypass, and they usually come back to see me because I'm their medical cardiologist. So I take over their care back after a year and a half. And they're like, no, you are the one. And it always, you feel great that day. You're like as if you're walking on a cloud whole day. And that's usually the best day of the week for me, when a patient identifies you.
So you travel far from home when you go to work, right? So, how does your work impact the local community here versus the local community at Reading, where you work?
So local community here, I try to help them out when they have an issue. Like I get a call from the local folks like, hey, I'm having this. What do you think this test is all about? Or should I do something about it? I usually answer their phone calls in this community of Allentown. Reading community, I contribute through, I've done radio interviews over there. I have gone to Wilson High School and spoke with the students over there. Uh, and mostly I'm a doctor there, so I contribute way more over there to the community because I see the community patients. In Allentown, I haven't been able to do as much because I don't work here and people don't really know me. The friends of the friends of the friends who know me, they feel free to give me a call and ask questions.
So moving into the mental health aspect, we're going to touch more on the patient side of that. So how often do you see mental health affecting heart or vascular conditions?
Oh, every patient, every patient. I mean, we see that all the time. Like, as a doctor, I go to the emergency room with a diagnosed heart attack. Like, I'm just going, ER calls us, hey, this guy's having a heart attack. Come see him. I go see him. Yes, you are having a heart attack. Let's go to the cath lab. I call my interventionalist team and they do the stent. They identify it. Like, can we stent it or should we go for bypass? The first question without them saying on their face is why me? So over the course of the years, I've been in attending for almost 8 years now. The first thing I tell them, we got you. We got you. You're at the right place now. Let's move. Focus, look forward, don't look back. Let's go. More psychological impact is on the bypass patients. When they
Before you continue, what is a bypass?
bypass is, so when there is a blockage in the coronary artery which causes a heart attack, you either go in, pass the block with a wire, put a balloon in, open it with the balloon, and put in a stent, which is like a scaffolding to keep it open. That's done through minimally invasive approach. You go through the radial artery or femoral artery and go up through the artery and do all that. But if the disease is in significant arteries, more than two, or if it's in an area that you can't really stent, you do bypass. Bypass is you open the chest and you bypass the blockage with either an artery in your chest or you take a vein from the leg and put a bypass. Like you go make a bypass from the aorta to the distal to the downstream portion of the coronary artery to bypass the blockage. So it's literally the chest is cracked open to do it for the most part. Big surgery, they come out in the ICU, they're intubated on a respirator for a day or two, generally a day. When they wake up and they look down, it's a gashing wound in the chest. Most of the time it's covered, but when they uncover it, it's a gnarly looking scar. It's a gnarly looking wound. And it's just the regret on their face is there. Like, oh, yeah, I got it. Breathing hurts, coughing hurts. That's where the family support comes in. We got you, don't worry. So I always tell them, as my pet statement for them, hey, you got the grafts, now let's baby them and make sure they do fine. Now let's make sure that these stay open for the next 14, 15 years. Because if you do the right thing, the arterial grafts usually stay open for the rest of your life if you take care of them. So I was like, hey, this is your second lifeline. Let's do it.
So then when it comes to that family support, what are the differences that you've noticed between patients with strong mental health support versus those who don't?
Compliance, medication compliance. Remember this patient who ended up getting a bypass? He just didn't get a bypass because he was doing something for days or weeks or years. He's been doing that thing for decades. And now all of a sudden you expect him that, oh, he's gonna drop his nightly ice cream and reach for something healthy. The family support helps in that a lot. There is always a thought process in patients' head like, yeah, whatever, man, I'm gonna die anyway. Let me just enjoy it. My best friend who's in Australia, a family doctor, he was recently telling me a story that his patient was not doing well and he was still smoking. So he told him, hey, you will die. The patient's answer was very clear. He said, Doc, I want to die with the smoke coming out of my mouth. So you can imagine that some patients who go through that, they kind of are like, whatever. Or they'll find something else to fix. I'm just going to keep on doing what I'm doing. But the family support helps in that sense. Whether it's the compliance side of things from being stubborn or depressed. So it's getting a big deal now in the hospital where we provide psychosocial support for the post bypass patients.
So how do patients typically react emotionally after being diagnosed with a serious heart condition?
It's always, as I said, the first thing is always, why me? And then when you talk to them about it, they understand that, yes, I did it to myself. And then some patients get very serious about it, like, yes, what can I do, doc, to fix it? And these are usually the guys, they go above and beyond and take care of themselves, and they do well. Now, as I said early on, prevention is better than cure. The more I see in my field, I'm like, once the damage is done, it never goes back to zero. It never goes back to zero. So I tell patients all the time, just don't let it happen. Don't let it happen. And that's where the preventative cardiology field has taken off. We see patients early on in their 40s, in their 50s. We do their blood tests, we their scans. They have no symptoms, and we are doing blood tests and coronary scans and all these things to risk stratify them. That, hey, how aggressive do we need to be with your care to minimize your risk factors? So the patients who get diagnosed with that, unfortunately, they haven't gone through that. So they're always a little bit withdrawn, like, why me, or what can I do?
Do you ever need to adjust how you communicate that medical information based on the emotional state?
Absolutely. Absolutely. Some patients are, doc, give me the facts. They hear it black and white. Some patients want it a little bit of they want a little bit of a fluff in there. They want it to be explained to them much better. And these are the patients that I take my time. I see them either early morning or late in the morning or late afternoon, where I can pull up a chair, sit with them, and go over the case with them, their case with them.
So then, have you ever had a patient whose mental state, like being positive versus negative about their situation, significantly affected their treatment outcome?
Oh, absolutely. Absolutely. Like the patients, there are studies done that patients who show up with a heart attack and who's a smoker and they continue to smoke, half of them die in the next 5 to 10 years. So that's the psyche of it, that we tell every patient, hey, stop smoking. And they continue. Outcome is dire. The medication is ridiculously good these days. So much so that if we find coronary disease and it's not significant enough, the guidelines say treat medically first, then go for a stent or a bypass. The medicine is so good, but you need compliance. So the psyche helps in that. On the other hand, people who are like, yes, what can I do? They're really motivated, they have family support to do it, and they have financial means to do it. Gyms are not cheap. But guess what? Roads are free. So it's the psyche, right? You will always find an excuse to eat something. You always find an excuse not to do something. So we see that all the time.
Does Reading Hospital provide integrated mental health support for cardiac patients?
So it depends on how the patient is. We can ask for it. The program is not integrated mental health, but if the provider asks for it, we have people to help.
So then, on a little bit more of like a personal reflection, a little bit we just talked about, what currently and what in the past had intrigued you most about psychology? I meant cardiology. I'm sorry.
So cardiology field I really liked because of my professor during my medical school years. He would turn the heart into a room and the doors as heart valves. And he would teach like that. And when I went through medical school, did my residency, I just found heart to be an amazing organ which has its own pumping, plumbing, and electricity. It's a clean organ. There is no blood, sputum, urine, or poop involved. There's only blood. And I love blood. Blood is never stinky. Blood is always clean because it's flowing in you. So it's a very clean field. And it's complex and yet very simple. That's why I like it.
Do you ever find yourself with med school patients, or not med school patients, but med school students that are a little woozy around blood? And how do you deal with that? You being someone who loves blood and works with it a lot and has no problem with it, how do you deal with med school patients who are not the same?
So I will talk about myself that I could not bear the sight of sputum. And sputum being the thing that you cough up. And especially when during bronchoscopy, during my pulmonology, the lung disease rotation, they would do bronchoscopy. So they would suck the sputum out during looking inside the lungs. And I'm sorry, but I'm going to make that sound. It would sound like... And I watched all my bronchoscopy with my ears closed. I could look at it, but I'm like, oh, okay. So now when I'm doing the TEEs, for example, the probe goes through the mouth in the esophagus. But remember, the esophagus and trachea is really close by. Esophagus is in the back and trachea is in the front. So sometimes you tickle the tracheal area and they cough. And you have to take the probe out to put it back in to, sedate them more and all that. And sometimes a big stringy sputum is attached to the tip of the probe. My staff knows that I'm not going to even look at it. They have a towel ready before I even take the probe out and they just clean it right away. So there are ways to deal with it. You know right away which field you'll be able to do it and which field you're not. It's good that you know it now as a medical student that, hey, I cannot bear the sight of this.
Have you ever dealt with medical students that had fainted?
No. I've heard about them. And that's common. It's not just, it's what we call it vasovagal syncope. Like you have heard kids standing in the morning assembly or a church choir or a wedding standing for a long time and whoosh, they go down like a flagpole. That's just the blood pressure goes down and heart rate goes down a little bit, they're woozy, they're a little underhydrated, I wouldn't say dehydrated because they wouldn't have been standing to begin with, so underhydrated. Yeah, we see that it's not as dangerous sounding as media and people feel like it. Just lie them down and raise their legs and get the blood flow going to the brain. They usually wake up within a couple of minutes.
So why vascular specifically?
So when I was doing my cardiology fellowship, which is 3 years long, it's actually cardiovascular medicine fellowship. But the vascular part of it was only 1 month long out of 3 years. And I realized that a lot of cardiology is obviously connected to the arteries, blood vessels. And on top of that, I always wanted to do interventional cardiology. When I came into medicine, I wanted to do cardiology, followed by interventional cardiology fellowship, where you put stents in the heart and legs and all that. But the lifestyle was very rough. And when I saw my mentors, that how miserable they are, I decided against it. So my mentors told me, hey, good job, you are deciding against it. You're not going to regret it. But now chase vascular medicine so that you can do the venous procedures. So I started to do the venous procedures with them, and I went to get better at vascular medicine. The venous procedures that I'm talking about are for varicose veins, like giant bulgy veins. So I do endovenous ablation, means we go in the superficial vein and burn it down from inside, or put glue in it and close it down. And then the giant ropey veins, we yank them out like a worm, make a tiny incision, hook them with the crochet needle kind of thing. Just hook them and slowly pull, hold it with a hemostat, and rotate like a worm until it breaks off, and it heals by itself.
So knowing you go fishing a lot.
Yes.
And so is this I'm just wondering, do you find your hobbies similar in some way to what you do at work?
So I would say it's more of a, you are what you are. For example, I like to fly fish a lot. And fly fishing is very challenging. You have to read a lot about bugs. You have to be like a baby entomologist to be able to fly fish. And that's kind of a cardiology and field of medicine as well, that you have to read a lot and you have to work as a detective to find what's happening, what's wrong. You have to be able to have the patience for trying different flies and reading the books in the time of the day and the time of the year, what water temperature, what's rising, what's falling on the water, and have to have the patience enough to talk to the patient and the family and the symptoms and sift through the tests to find out the diagnosis. So yes, it does kind of a match. Patience is the key, I would say. Impatient people who do not have a lot of patience, they might not fish. They might have other hobbies. They might not be in the field of medicine per se. They might be in a different field like pathology. Go cut the body, take the tissue out, look at it under microscope. No need to wait or anything. This is the forensic medicine, not forensic medicine, but pathology. They get dead bodies or dead tissue. They just need to cut it, slice it, look at it, go. So it definitely does affect your job and your hobbies.
Moving on, science as a whole is constantly evolving and constantly changing. And so, do you ever find yourself noticing differences between what you were taught in medical school and seeing that it has changed since you've grown?
Absolutely. When I was in first year med school, for example, metoprolol was thought to be bad for heart if they have heart failure, because it slows the heart down. It's a negative inotrope, means it reduces the strength of the contraction. And now metoprolol is the first drug for heart failure. You don't have to go far. Aspirin, low dose aspirin, was given to everyone as a preventative drug. I would say if someone brought their dog to the cardiology office, they would end up getting a prescription of aspirin for the dog when they were going out. But over the past 5-6 years, the paradigm has shifted. If you do not have coronary disease, arterial disease, stroke, or any hardware in the heart like artificial valve or patches or occluder devices, you don't need aspirin. We've been stopping aspirin. They show up, why do you take aspirin? Do you have blah, 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 this? No. You know what we're going to stop at? But I've been taking it for decades. It's time to stop. Stop it. So big changes. Recently, not med school. I'm talking about 5-6 years.
A quick question, just again, I'm sorry, but you just talked about how you have to tell patients that after decades you have to stop them on something. Do you ever find yourself making mistakes, and how do you find yourself owning up to them in front of the patient?
Of course, absolutely. I mean, don't go far. I saw a patient in the office, and I looked at their ECG, and I'm like, oh, this is atrial fibrillation. Atrial fibrillation is an abnormal rhythm of the heart that can cause stroke. So if someone is of appropriate age and has other comorbidities, you need to start them on blood thinners to protect them from stroke. This patient was coming to me for diagnosis of AFib at the family doctor's office, and I don't have that ECG available, so I had to rely on my ECG. And I look at my ECG, I'm like, that's AFib, because AFib is very common, very common. So, and I was like, you know what, I'm going to start you on blood thinners. Blood thinners are safe, but they're not without side effect. They can make you bleed. Blood thinners' main job is to make your blood as thin, twice as thin as the guy who's not on blood thinners. What do I mean by blood thinner? Let me give you a little bit of a background. If one person on blood thinner and the other one not on blood thinner, they cut their finger, same depth, same length, and the not blood thinner guy's bleeding stops in 2 minutes, the blood thinner guy will take 4 minutes. So it's twice as quote unquote thin. I started the patient on blood thinners. Now I sent the prescription to his mail order pharmacy, not even local pharmacy. And he was in a facility. And now he's gone. An hour later, I'm writing his note, finishing up, and I'm looking at his ECG. I'm like, that doesn't look AFib. On the first look, it looked AFib. So I went to my other cardiology partner in the next office. I was like, hey, look at this ECG and tell me, what do you see? And he's like, he was like, yeah, it's a little abnormal, but it's not AFib. He knew what I was going for, because that's the first thought. I mean, for me, in a rush of things, patient after patient, I was like, oh, that's AFib. But when I had a little bit of a moment to sit down and ponder over it, like, that's not AFib. Now what? Pick up the phone, call the patient, sir, I looked at your ECG again. It doesn't look AFib. Take it easy. I'm gonna call your mail order company in, where is it, Wisconsin or Chicago, and ask them that I sent a prescription. Do not send him the medication. Xarelto is $500 a month if you have bad insurance. So I call his mail order company, talk to them. Now I'm like running late as well, because this is not part of the usual daycare, right? So I call them, I speak with them. The lady was like, oh, yeah, sure. A day later, the facility calls me. The doctor said Xarelto, and then the prescription is coming or not coming. They said the doctor, what's happening? So they don't even read my note. They just call the office. So I call the facility then. And I owned up to now a third person. I owned up to patient. I owned up to the pharmacy. Now I'm owning up to the facility that, hey, I thought it was AFib. I was wrong. It's not AFib.
Mhm.
Everything's fine.
Yeah. Mm.
No harm, no fault. But I mean, identification is the key. If you beat around the bush in any field of life, the opposite person will know you're not sincere. Anytime you think they're not going to know, they're going to know. We have an inbuilt face reading face reading machines. Honesty, sincerity shows. So own up. I'm sorry.
Have you ever owned up and gotten a negative reaction from a patient?
Almost never.
Okay.
I can't even recall that. I mean, by the grace of God, it hasn't happened frequently, but whenever it has, patients always appreciate it. Patient was yelling, "Oh, I had a test done. Nobody called me back. The person who ordered the test had retired. Now someone else is taking care of his test results, and it's divided amongst people to take care of. If someone didn't call on time, it wasn't a bad test. It wasn't an urgent things are taken care of right away. It's cardiology, matter of life and death. It was a normal test, but nobody informed the patient that it's normal. Of course they were frustrated, and the people who are responsible, they're like, it's normal, we'll call them. I was right. I'm so sorry, this is our mistake. Dr. So and so is not here, so it's been assigned to other doctors, and they have their own in basket to take care of. They are taking care of that doctor as well. My apologies. I'm sorry. We should have taken good care of that. Patient forgot? Yeah, sure, no problem. Thank you. Done.
But to touch a little bit more in what lessons do you think you kind of, like what personal impacts have you felt through your job?
So the mental health wise you're talking about, or owning up to your mistakes you're talking about?
Overall,
Life lesson. Hard work pays off. Hard work pays off. I mean, whether it's hard work early on, late, middle of your life, now, today, yesterday, tomorrow, hard work will pay off. Hard work pays off for your career wise, your patient care wise, financially, health wise. I mean, it takes a lot of hard work to work 8 to 10 hours days and then come home and exercise. It's hard work. It's hard work that, people on the weekend are going round and about, and you are sitting down reading up on new articles, but that pays off for the patients. So I would say hard work and honesty, it goes a long way.
so then you know that we have a mental health podcast for teens. How do you think these life lessons apply specifically to teens going through high school?
Again, hard work and honesty about yourself. Have you done enough to achieve your goal? Could have you done more? You if you are honest with yourself, you'll automatically work hard. So it comes down to honesty and hard work. Honesty and hard work. And it pays off. If not today, tomorrow it will. If you fail with honesty and hard work, it's just making sure that tomorrow you'll succeed.
So we've obviously touched, into the human connection and the science. Which do you think medicine comprises more of?
Well, human connection. I mean, that's what I mean. The cardiology part is really interesting in that sense. For example, I was in the office today seeing patients, and my colleague and really good friend of mine, he says, "Man, look at that! how blessed we are that we have this job, that we go to work, chat with people, order a bunch of tests, and go home.
Yeah.
I sit with patients, like the patients that I know that I've been seeing for a year or two, more than 2 years. I've seen them like 3, 4, 5 times. Half the time we're talking about hobbies. Hey, how's your pet doing? Hey, did you grow something in your garden? A patient walks in and she's like, we were talking, like, how was your Nepal trip? And I'm like, how do you know? He's like, you told me last time you're going. I was wondering how did it go. A patient wrote me a card. When I came back from Nepal, I received a card that wish you all the best on your Nepal trip.
Oh.
So it's about how you make it. Doctors don't share private life with them. My patients, no patient that I know. They're like, oh, the patient was like, oh yeah, I'm going to Australia. What do you think? I should take blood thinner. I'm afraid I might get a clot in the leg and all that. And I was like, yeah, I went to Australia last year. I didn't take any blood thinner, but I got this seat and that seat. You can straighten your legs, the bed, this. You're like, oh yeah, I did that. Where are you gonna go? This. I went there. So I'm sharing the private information with them. But that's what makes the job really fun. You're having a chat with them. At the end, you write a note and you help them. You help them, chatting with them, ordering the test, and got paid for it. Isn't it amazing?
Sophia and I do a lot of our own research into how to communicate with patients, and I know in our research we've seen that there is a difference between doctors who stand versus sit down with patients.
Oh yeah, absolutely.
And
Absolutely.
you see a difference in how patients react to the doctor?
Oh, absolutely. So our outpatient means the office setup is always you sit. That's like, it's just gonna look awkward if you're like standing anyway. In the hospital, it's different. You can stand, you can sit. That's almost standard, almost everywhere, that in the office, the doctor's gonna sit. In the hospital, the way I do it is, if I'm seeing a patient for the first time, I'm gonna pull up a chair and sit with them. If I'm talking with the family, I'm gonna pull up a chair, sit with them. If I've already seen them and I'm just updating them, I'm not going to sit, because this is the time is important to spend on a patient who needs more time. I'm just updating them. The plan is in order. Okay, we are giving you water medicine to take fluid off of you, and you are 2 pounds lighter today. You need to go 4 more pounds. We're gonna continue. See ya, bye. Compared to, okay, sir, this is happening, that's happening. We're gonna do this. We're gonna do that. So that I need to pull up a chair. Computers have made it's very difficult, on top of the insurance requirements of the documentation. For example, you can't just say chest pain, likely cardiac test. Chest pain, how long did it start? Where is the chest pain? Is it radiating right, left, back, front, wherever? What makes it worse? What makes it better? Is there any other associated symptoms? All of these things you have to document to get paid by insurance. So you have to document all that. So what doctors do, they type and talk. And you miss on the human part of the whole interaction. I am bad with completing my notes because I never type in front of them. At the end of the day, I'm writing notes, or I write my today's note tomorrow early morning. I go to work an hour early and finish my yesterday's note before my day starts. Because I like to just have a chat with them. I have a piece of paper in which I just take the pointers to recall myself the story. And that's it.
Do you find that affects the insurance at all of the patients?
No, because no. It hasn't been detrimental. Patient care is always good. These doctors who type, the patient care is not affected. You might miss subtle clues, but they're subtle enough that other tests make up for it. You will miss the sadness of their face, what's happening with them. You will miss this the subtle eye roll when you say, I'm going to order this test. They're like, oh, another test. So when I say, hey, let's go for this test, and they're like, oh, and I'm like, I understand, let me go over the test with you. What did the last test show, and what would this show that didn't show? And you pick up on it right away, and the patients love it. When I say, hey, yeah, you know what, I'm going to write your note later on, I'm just taking quick notes. They're like, yeah, rarely I see a doctor looking into my eye, talking to me.
Oh, wow.
And the other aspect is calling them. Doctors don't call them with the result with the EMR. You just send them a message. So when the test is abnormal and I need to update them and do more, I pick up the phone and call them. They're like, oh, the first patient I called, they were like, I can't believe my doctor is calling me. They never call. I'm like, yeah, I need to go over some results with you, and it doesn't look good. We got to do this and that. And it wasn't that bad, but I mean, when you hear in a message, okay, the test is abnormal, we're going to do this test. You want to know what's abnormal, what's the extent of it, am I living, what's the prognosis, all these things. So when you call, you get their anxiety taken care of as well. That's the human aspect I really enjoy.
Like, based on what we've heard today, we already know a little bit of the answer to this question, but would you choose this career again?
Of course. There is not another job in the world that I can think of that you get to be thanked and paid at the same time. Financial side of this field helps because the road is very long. If you are studying or training or going to school combined 10 years, your peers have started to make money 4 years, 5 years ahead of you, and you get to be paid the same amount. Not worth it. I'm sorry to say, helping people is a huge part of it. Finances help as well. So this field, you get paid and thanked and appreciated. I mean, I can't think of any other field like that.
I can't thank you enough for being on this
Of
podcast
course,
and
no.
speaking with us.
It's an honor. It's an honor. Thank you for having me.
Of course. Just one more question. I think I'm wondering this because now I kind of want to do cardiology. If there was another profession that you would go into, like in the medical field, what do you think is like the second most?
Orthopedics. Orthopedics and cardiology were two things that I wanted to do. They were very neck and neck for me. I mean, it is slightly different because orthopedics is very nails and hammer and all these things. But I was inspired by an orthopedic doctor and a cardiologist. So the divine power guided me into cardiology because I was looking for research in either cardiology or orthopedics to better my resume before I could apply for residency. And the cardiology research was available right away, and orthopedic I had to wait for a year. So I just started in the field of cardiology like that, and here I am.
So I have one last question. I know your son wants to go into orthopedics, right? And so you're of course, as his father, you're going to help him and guide him through his schooling, his medical school, everything. What do you think is the most important piece of advice that you can give him besides the advice that you've already given us, hard work, honesty? What else specific to medicine and specific to his path through the medical school? What is the most important piece of advice that you can give him?
Keep your head down and keep going. It's a long road. Surgical road is longer than just the field of medicine. My road was long because I was a foreign graduate. So I had to do 3 years of research in cardiology, 3 years of internal medicine residency, 3 years of cardiology fellowship, and 1 year of vascular medicine fellowship. So my 3 years of research was extra. So after medical school, I spent 10 years to become an attending.
Oh, wow.
And orthopedics is essentially like that after medical school, you have to train for about 5-6 years if you're not doing subspecialty.
So you, after med school, took 10 years of schooling, and now you're 8 years as an attending.
Yes, almost 8 years.
And it seems like you have a lot of experience in what you do. A lot of experience.
Yeah, I mean, if you see, yeah, it's a long road. So my advice for him would be just, eye on the price. This is what I want to do. Now, whatever thing motivates you, use that as long as that goal is ethically right.
Well, that's all the questions.
That's all the questions.
Yeah.
All right,
Again,
wonderful.
thank you so much
Of
for being
course,
here.
of course. Thank you for having me.
That's all for today. Welcome back to the Tea Journal.
So for this tea journal, we are just going to reflect on the interview and basically just summarize our key takeaways.
Okay.
So the first topic that I think we want to touch on is what the interviewee's job was all about.
So basically, we interviewed Sophia's dad,
Mhm.
and he's a cardiovascular cardiologist at Reading Hospital.
So he specializes in patients with vascular problems and with cardiac problems, right?
Yeah. And he typically sees patients. He said his most common, I don't know what you would say. I want to say affliction, but that's not right. Oh, no, I can't think of the word. Problem diagnosis. There we go.
Sure. Is
Most common diagnosis.
high blood pressure.
Yes. And then next to that, he said coronary artery disease.
And then cholesterol.
Yes. And he sees a whole myriad of things,
Mhm.
and, he runs labs, testing, stress levels.
Rounds in the hospital, talks to
Mhm.
patients, reads echoes, all of that.
Yep. And he's kind of the first step in preventative care for some of these patients,
Mhm.
but also identifying these problems.
And
right.
so the next topic that I think we want to move into are what are our impressions of the job and their field in which it resides.
Honestly, for me, the medical field has been so intriguing since when I was little, honestly. But, I've always been an indecisive person, so I've bounced back and forth between what field I want to go into. I've always known I wanted to work with kids, but your dad really sold me on cardiology today.
Yeah, I was watching your reaction when he was talking, and it was like one specific moment. What was it? When he was talking about pulling the worm, like a vein, like a worm, or an artery, like a worm out of someone's leg.
It was a vein, the varicose
a vein.
veins. Yep.
Okay. Of course you were listening. Of course you were listening. But yeah, and I could see a reaction. You were like, "Wow, that was
I didn't
cool."
even know I had a reaction on my face.
That's what I knew.
It was like a mental reaction.
I could feel when you were like, "Oh, I might want to do this." You know what I mean?
And Sophia knows me really well too. But yeah, I've always been interested in the heart and cardio and the cardiopulmonary system, but also neurology. And it's also interesting. But today specifically, I got to really hear the meat of the job. And we do this in our medical class, MI already, and we do career journals, and I'm pretty sure we did one on a cardiologist.
I think at one
point, maybe it was in PBS back in freshman year, but I feel like I distinctly remember writing oh, this is a cool profession, but it may not be for me, because on paper it kind of, no offense, it sounded boring to me, because I was like, oh, it sounds like I'm gonna be stuck in an office all day, and I've always been I want to be on the front lines of saving a patient's life. But in reality, your dad is on that front line. He identifies it. He's the one that says, hey, you need to go get this procedure because this is what I've seen on this echocardiogram, or on this, stress test results, or whatever he sees. He's like, hey, there's a problem. Let's, find a way to fix it.
Absolutely. And in terms of myself, I don't know if you remember this at all, but I was asking a lot of questions about people fainting at the sight of blood and people getting woozy. I myself am not super good with like the internal body very much, or
Right.
like blood or anything, and
Mhm.
I was just trying to get his understanding as to what that meant for me
Right.
in the future. And I know cardiology isn't necessarily the field for me, but understanding the mental health nuances of the profession is extremely interesting.
Yes. And the stuff that he touched upon in terms of mental health, it really shines such a bright light on how much it affects your mental health, or
Mhm.
not your mental health, your physical
Yes.
health, in terms of just your heart. And if you can imagine that's for your heart, which is a major organ in the body, imagine what that does to other parts of your body, like your liver,
Absolutely.
your stomach.
And then he
Even your
also,
brain.
absolutely, and then he
Mhm.
also mentioned stuff about your support system, which we talk
Yes.
about on this podcast, and the importance of your
Yes.
support system, and how in episode 7 of both season 2 and season 1, we have talked about
Mhm.
how important the support system is, and hearing it from someone who deals with it from in their day-to-day life and sees the importance of it
Yeah.
was so impactful to see.
Yeah.
It was so validating to know that you really do need your support system. It really is that important.
Yeah. And I feel like that's something that's very often overlooked in the medical field because it's very, concrete to an extent. But one of the things that I really appreciated that he talked about was how the medical field isn't black and white.
Mm-hmm.
And I think that's something a lot of people miss. And that's partially why I connect to it because, as concrete as it is, the facts and this is what you got to do for this, this, and this. There are those small complexities in every human being that, he was saying one person could be exact, gender, like, oh my God, gender, place of, wow, why can't
Wow.
ethnicity,
Ethnicity.
whole, like, on paper looks exactly the same. Same height, same weight.
And yet one medicine works for one, and that same medicine will not work for the other person.
And it's those small nuances that it's just like, that's what makes the field so exciting. And just the complexity of connecting with a human and that seeing that impact on the patient just overall is
really,
why I love it so much and why I find it so interesting. And I kind of loved that I was able to see it from, your dad does both like inpatient and outpatient. So to see it from both those points of view was just really like enlightening for me, I guess.
Yeah. I feel like the medical health.
Yeah.
The medical profession, it really is just a big pool of gray paint.
Yeah. And it's honestly like, because there's so many things like, even he was saying like, the food you eat, when you eat it, how many calories you take when you sleep, how long you sleep, what is your sleeping like?
Yeah.
Just those small little factors that like 90% of us don't even think about really affects like major parts of your body is just so fascinating.
And the way different parts of medicine are so interconnected, your mental health, your diet, your exercise, all of these tie into one small thing, your cardiac health, for example.
And again, I think, because this is our mental health podcast, just being able to see how much that mental aspect really does tie into, your physical health. Like, your dad just kept repeating your psyche. Your psyche really does control so much. Even if it's not like, oh, if you have a positive mindset, like you're just going to be magically cured.
Right.
Like, no, like he was saying, if you're willing, if your psyche allows you to say, hey, I may have messed up early on in life and, involved myself in terrible habits, but I recognize that now and I'm willing to comply with what the doctor is saying so that I can get better. That's, overcoming those mental constraints that you may have. And that's super important when, especially in a field of cardiology, because again, like your dad said, it's a matter of life and death sometimes. Because again, it's such a vital organ.
Absolutely. And then also hearing about taking care of your own mental health as a doctor, hearing that was extremely empowering, honestly, because in order to take care of your patients, you need to take care of yourself.
And that touches into a lot of the stuff we already talk about and how, Sophia said way back in our very first episode, you need a full cup to be able to pour for others. And that's just like, you can't pour from an empty cup.
Yeah.
You really can't. And that was just such an important lesson. And, the life lessons that, he touched upon.
Absolutely.
Hard work and how we saw how it paid off. I mean, just hearing about the stories of patients coming back saying, thank you so much was so impactful.
Absolutely. And then moving on to one of our last topic is the impact of their job on the community. I feel like we already touched on about what we learned, our impressions, and what the job is all about, but how does it help other people? And we already talked about just very briefly the thank yous that he's gotten from other people. And I feel like you can really see the impact based on how many people have come back to thank him.
Yeah. And just the visibility of certain things like that. Like, you know, one of the things he said that's super important in terms of eating for kids and just lifestyle choices and all that and preventative care is education.
Absolutely.
You need to get educated. And that's something that, you know, really stuck with me. Like, I think we all know that intrinsically, like, you know, education's great. We need to know this. This is how we learn things. But, you know, that importance and him highlighting how little we really know, one, about the human body, but two, about how we can take care of ourselves and why it's so hard for us, you know, can really push people to, like, reevaluate their life. And, you know, he was saying he's spoken on radio shows in Reading, in the Reading community, and gone to, I think he said Wilson High School.
Yep.
Wilson High School to talk to the students there.
Wilson. Yeah, Wilson.
Yeah, I think it was Wilson. He went to a high school
in the Reading area to talk about his profession.
And just increasing that visibility for students and just, you know, increasing awareness is so important. And I think that's a huge contribution to the community, that people, you know, just sometimes want to look over things unless it's kind of thrown in their face, for lack of a better word.
Absolutely.
But it's huge.
It really is.
And honestly, your dad has made such a huge impact. Like, I didn't even know he did half of those things.
Oh, really?
I didn't know he spoke on radio shows. That's, like, cool.
Yeah, right?
That's really cool.
I shadowed him when I was in between my freshman and sophomore year, I believe. And you know me, I'm not good with blood. I'm not good with anything. I was with him.
How did you do that?
I didn't see a lot of blood. Really? Actually, I didn't see a lot of blood at all. There was one time that I was there for an operation. Ooh. And I couldn't watch it.
Oh,
I was outside the room.
Yeah. You know, as my loving, caring friend, you would never be able to sit through that operation so you could come back and give me details.
No.
Like, you'd just be like, oh, you could never come back and be like, it was so cool, because you'd just be like, I didn't watch. I turned around and made
Do you remember that one time when we had, like, a cadaver in our biomed classes?
Yes, I do.
I was not there. I walked in. I was ready. I was mentally preparing myself. I was trying to get there. I was like, I am going to watch this. Put on my gloves, put on everything. I sat there, looked at it, and I was like, nope. And I was just like, took off my gloves. I was like, hey, Mrs. Ciala, I am so sorry. I was literally dizzy. I was trying to hold myself up. I was like, can I go? She's like, yeah.
Did she say fine. You didn't have to ask?
Yeah, but I mean, like, I was already gloved up. I was ready. I was ready to go. And then it was like, no.
What about it made you, like, feel woozy? Because for me personally, I've never I've seen a full body cadaver.
No way.
I went to a science camp over the summer, full body cadaver. I mean, I didn't see the skin, like, they had already, you know, dissected it. And I think if it was, like, you know, it wasn't dissected yet, I feel like I would have been, like, a little taken aback, because it's like, oh my God. Because, you know, your dad was talking about, you know, detaching emotionally from that element. And as much as, like, I respect the human and I respect, you know, who's there, I feel like when it's dissected like that in front of me, like, I'm able to pull myself away and be like, it sounds horrible, but it's like, it's just the parts of the body, and I'm just feeling it as, like, these are the parts of the body. And of course, when I leave the room, I think about, like, oh, the family, and I wonder what they were like, and that part was like, oh, whoa. But yeah, full body cadaver was fine. Standing, not dizzy, not woozy at all.
To be honest, I don't really remember exactly what it was. Was it an open knee? I feel like,
it was like it was almost like it was cut, like it was like you looked at your knee and then they just cut it open.
It was just something about the fact that I knew that was on a person beforehand that just made me sick.
Right.
And it was like, that is one of the reasons that I'm, like, very into mental health. I don't know if I've ever said this on the podcast. I don't know if you've ever said what you want to do either, but I want to be a psychiatrist. I want to go into psychiatry.
Oh God, I don't know if we ever have.
Yeah, I mean, I want
2
to.
seasons and we still
I mean, this is the perfect time, because it's about the medical profession. And so I guess we can talk about that for, like, a split second. I want to do adolescent psychiatry, and I want to help teens who are under medicated and who have been over medicated, and try to help them find that balance.
And, you know, personally for me, I think I was saying this earlier, I want to go into specifically pediatric surgery. Now, after today, Lord knows what I want to do, what type, what specialty, but it's, for me, it was either general, neuro, which because I just love the brain, I find it so fascinating, or now cardiology, because, man, I love the heart too. Like, it's just so interesting. Cardiopulmonary, all that.
And I feel like the most important thing to mention is that we both want to help kids.
Yes.
And that is our driving force.
Our driving force.
Absolutely.
Our main principle is we want to work with kids.
Absolutely. And not even just kids, but also like teens. Like us. Adolescents.
What is I don't know, what would you call that? The adolescent childhood age.
Yeah.
Anyone who's not an adult. Although, I mean, I guess I would see adults, but I prefer to see
I wholeheartedly agree with that.
0 to 18.
Yes.
There we go.
Yes, absolutely.
But anyway.
Those are basically our main takeaways. So that pretty much wraps up our tea journal for this week. Thank you so much for listening to this episode.
I hope you'll join us next week on
Sip and Spill.